All right, thank you very much, ladies and gentlemen, for waiting. Good evening, I am Cornelia Sendegere, and we shall start off this CME with a few poll questions for the audience, just to get a feel and to get into the CME and kind of try to understand some of the things that are going to go on. So with the poll questions, you will be required to answer as soon as you see it, and we shall take about a minute for the poll questions. And once that is done, then we shall review the poll questions during the time the presenters end their presentations, and they will have a chance to respond to the poll question. So we shall start off with a simple question, and this is just to assess the audience to see if there's been any form of experience in the diagnosis of brain death. So please feel free to respond to this. So do you have any experience in diagnosis of brain death? I think about 56% of the audience has responded. Please, if you see the poll, just say yes or no, and then we shall review and see what everyone else. So in about 5 seconds, I'll probably close the poll. Okay, so the poll has ended, and I'll share the results. So as you can see, 82% of the audience says yes, and only 18% says no. Okay, so this is going to be interesting, going through the discussion for this. So let's go to the next poll question. And this is another one. Have you ever diagnosed brain death as the primary care provider? We are left with about 20 seconds to close the poll, so feel free to respond as soon as possible. I see about half of the audience has responded. So that's good. All right, in 5 seconds, I'll end the poll and share the results. Okay, thank you so much for responding to that. So these are the results. So we have over 62%, 76% of the audience has actually diagnosed brain death as the primary care provider. So this is quite interesting too. And I'm looking forward to a very interactive discussion going forward. And then then the other questions relate to the knowledge of diagnosis of brain death. So please feel free to respond to this as soon as you see it. So here it is. We have a minute, and at 17:10 we shall be able to start. So does the diagnosis of brain death require a patient to be on mechanical ventilation? Yes or no? Okay, I'll end the poll now. So from this poll, we can see diagnosis of brain death requires patient to be on mechanical ventilation, yes or no. 67% of the audience says no, and 33% of the audience says yes. All right, and then the final poll question is going to be, again, about our knowledge of brain death. So here it is, brain death refers to brainstem death, true or false? Okay, we have about 10 seconds left, which I'll hand over to Dr. Joyce Kalungi and Dr. Erasmus to start the CME. So I'll end the poll now. Thank you very much for your responses. So we have the statement was brain death refers to brainstem death, true or false? 74% of the audience said true. All right, thank you all very much for responding to that. We shall come back to the start of the CME. Dr. Erasmus, please feel free to take over and introduce the first presenter as we jump into this CME. Thank you.
Thank you so much, Dr. Cornelius, for running the polls. Thank you to the participants for being part and making it count. Again, in our usual big numbers, I see the numbers are increasing by the minute. Welcome to our critical care seminar. This one will focus on brain death, and I know that you've already gotten introduced to the subject. You've been answering some poll questions. The goals of today's seminar really to help us get to know how to, to deal with brain death as critical care practitioners, or at least in the critical care practice. The first objective will be to understand the definition and the concept of brain death, and to understand the approach to diagnosis and communication of aspects around brain death. And finally, to appreciate the critical ethical aspects relevant to brain death. As already indicated in today's menu, we are starting with a clinical case before we proceed the rest of the chat. So Dr. Joyce Kalungi is an anesthesiologist and a fellow in the SCALE critical care program. She will be taking us through the first aspect of today's program, which is a clinical case that will introduce us to the subject. So Dr. Kalungi, kindly share your screen and start.
So I'm presenting a 22-year-old prime gravida who presented to one of the national referral hospitals in Uganda. She was a referral from a peripheral clinic, and the presenting complaints was loss of consciousness and seizures. She had been unwell for 2 days prior to admission, with history of severe frontal headache associated with numbness in the lower limbs. There'd been no history of fever, vomiting, or trauma. So she's admitted. Oh, I don't know why it keeps doing that, but yeah. So she was admitted illness, in this instance, malaria. However, on day 2, the symptoms seemed to progress with what was seen to be an episode of syncope and generalized tonic-clonic seizures that were refractory to the first-line medication that the patient got. And unfortunately, the patient did not regain consciousness. She had no known drug allergies, and she had had a last meal around 9 a.m. that day, on the day of referral. Sorry, so she reaches the referral unit at around 15:00 hours. Let me repost. She arrives at that, and at the time of admission, she's seen to leave the ambulance to the emergency room, and she was having a generalized tonic-clonic seizure that lasted about 30 seconds. On the primary survey, of course, she had a swollen tongue, which was had been bitten. Breathing, there was no chest movement. She had an SpO2 of about 40% on room air. The circulation, when the monitors were connected, she had a pulse rate of about 54, which was deemed to be a sinus rhythm. Capillary fill times were about 2 seconds. And the blood pressure was as noted above, with a systolic of 189 and a diastolic of 110. She had a GCS of 3 out of 15. Pupils were about 4 millimeters non-reactive, and the random blood sugar was about 12 millimeters, or rather 12 millimoles per deciliter yeah. So the quick problems that, of course, were identified was we thought the patient had a respiratory arrest, was probably in status epilepticus, and was displaying signs of Cushing's triad that was due to intracranial hypertension and herniation. So the plan that was done, bag mask ventilation was initiated immediately with an aim to hyperventilate the patient because we thought there was ICP, and then the patient was intubated. With nothing. That's to say, they put a tube of about 6.5, and they continued to bag masks ventilate the patient, and later connected them to a ventilator with the above target. So, an SpO2 of about 94% and an entire of about 35. Yes, so while hyperventilating the patients, there was a drop in the blood pressures, the systolic blood pressures from what was deemed to be hypertension at about 189 to about 80. And the patient had a mean arterial pressure of 55. So large bore cannulas were inserted, and the patient received hypertonic saline, and hypertonic saline, 1 liter of normal pneumosaline as well, and vasopressors were initiated. The target was to maintain a mean arterial pressure of about 70. The patient also received anticonvulsants, that was IV diazepam, about 10 milligrams. They were reloaded with magnesium sulfate, that's about 14 milligrams, and phenytoin at about 15 milligrams per kg, and labs were taken off as written there. So the secondary survey, when more history was taken, which was basically collateral, review of other systems was non-remarkable. The patient had attended antenatal about 3 times. She started at about 16 weeks and had last had a visit at around 30 weeks of amenorrhea. She had been treated for a urinary tract infection, but had otherwise had a normal pregnancy, and hypertension had never been detected. She was, the family history was a businesswoman who was married, did not smoke or drink. For the past medical history, she had been admitted in the clinic with what was written as borderline blood pressures and managed for malaria on day 1. She had received about 2 doses of artesunate. However, on the next day, the symptoms of the patient seemed to worsen, as she was noted to have a high blood pressure, and she started convulsing. So she was given hydralazine, 10 milligrams 1 dose, and then reloaded with magnesium sulfate. However, after receiving about 2 doses of magnesium sulfate, the patient started convulsing. We're told that started between 1, and that's when they referred the patient, who arrived at the peripheral clinic at around 3 p.m., still convulsing. So at 17-20 hours after the primary survey had been done and some resuscitation had been done, the patient is re-examined, and they had a GCS, or not, they had a GCS of 3T, that's with an endotracheal tube in situ. So the pupils were about 6 millimeters, non-reactive to light. There was no gag, no cough reflex, no corneal reflex, no oculocephalic reflex, and the apnea test was not performed because the lady was pregnant. They didn't want to affect the fetus. So she had an ETT in situ, about 6.5, secured at 24 centimeters. There was no spontaneous respiration at this point. The patient was connected to the ventilator with a rate of 20 breaths per minute. She was in SCVC mode with a PEEP of 6 and a tidal volume of 400 and an FiO2 of 50%. She had a pulse rate of 77 with blood pressures of 107. The mean arterial pressures were 72, but at that point she was on noradrenaline, about 0.12 mics per kg per minute. Abdominal exam, she had a fundal height of about 37/40 with a fetal heart rate that was 140, and on VE the Os was still closed. So labs were taken off. Basically for CBC, we see there was the white cell count was about 12,000 with a neutrophil predominance. She had a platelet count of 90 with an HB of 14. The renal functions, she had a sodium of about 137. The potassium was 3.4. Urea creatinine seemed to be within normal range of 2+. So brain CT scan was done that basically revealed a bleed. This was a non-contrasted CT in the right caudate nucleus, extending into the ventricles. That's both the lateral ventricles, the third and fourth ventricle. Sorry for that, with signs of acute obstructive ventriculomegaly. Let me share again. So this is the brain CT scan. You may, I don't know if you're able to see it clearly. I pray that you are. I have a video, but I wasn't able to sort of upload it onto the slide. I failed. But this is what the CT scan really looked like. If you're interested in the video, we'll see it. So our differential diagnosis, of course, we had a prime gravida at about 36 weeks of amenorrhea with an intracerebral hemorrhage and signs of severe ICP. We thought with still a viable fetus, we thought the cause of this was probably eclampsia, and we thought there was a probability that the patient was brain dead because at the time of examination, there were no signs of brain death. The second exam, there were no signs of brain function. I don't know why my thing keeps doing that. Yeah, the other differential diagnosis, of course, was probably an aneurysmal bleed. So the plan, we admitted the patient in the ICU and continued supportive care, basically medical management for ICP. We needed an urgent neurosurgical review. When the obstetricians reviewed the patient, they thought that the major thing was to deal with the ICP, and we would ripen the cervix with misoprostol and continue augmentation with oxytocin. So the neurosurgical review was basically for surgical management of ICP, that was either to insert an EVD or to do a decompression. And then we evidently had a family conference to update the attendants on what was going on. So the patient was reviewed by the neurosurgeon at about 22:00 hours. And from the examination, there was still no signs there were no brainstem reflexes. So the cause of whatever was going on was evident on the CT, which was an intracerebral hemorrhage. And according to them, they thought that the prognosis of the patient was too poor to benefit from a surgical intervention. So they thought the goal of managing this patient should be to deliver a live fetus. Yes, and so we continue the supportive care and basically deliver a live fetus, and basically to have a family conference with attendants and brief them on what was going on. So we continued with monitoring of labor, and on day 2 at around 8 a.m., a baby boy was delivered about 2.4 kilograms with APGAR scores of 5 and ETA 7. The baby was taken to a NICU. Examination of the placenta revealed a concealed hematoma, and at that point they thought probably the patient had maybe a concealed placenta abrupture as well. The neurological examinations had stayed consistent throughout the past 12 hours, and without surgical intervention, the ICU team had no, there was no indication to continue managing the patient after the baby had been delivered. So we had a family conference at about 12:00 hours to discuss withdrawal of care, and the vasopressors were stopped at that point. The patient had a cardiac arrest at around 14:30 hours. Yes, that was it.
Thank you very much, Dr. Joyce, for that clinical case. We shall be welcoming questions to the presentation. And in the meantime, would like the team to be posting their questions on the chat when the presentation is ongoing. So, Dr. Cornelius, I don't know if you might have a poll running right now before we welcome questions. Hello. So, for any questions that you might have, kindly unmute and then ask. So maybe Dr. Joyce, I'll start. In terms of the conversation on getting the baby out, how was it with the family of the patient? How was it? How did they receive the information regarding, the catastrophic injury you're talking about the patient? as well as the need to deliver the baby. How was that conversation held?
So on the first admission to the when the patient was admitted to the ICU, we had informed the relatives that the patient had gotten a stroke, and we were not sure what the outcome would be. However, we needed the opinion of an expert. So when the neurosurgeon arrived, and she said she was not going to intervene surgically, the next goal of management was to deliver the baby. So we talked to the attendants, and we told them that the mother was not going to be able to, would not survive. However, since she still had a live baby inside of her, I guess that's really direct English, our goal of care was to deliver the baby. So I would say it's always confusing telling that or explaining that to the patient, in my opinion, especially things regarding brain death. But of course, they still had some hope, as you know, very few people understand the concepts of brain, like literally the concepts of brain death. So they would always ask, but can she survive? Is there anything that we can do for her to survive? So I would say it was still confusing for them. However, after the baby was delivered, I think they sort of accepted what the outcome would be. So for me, just to answer the question, I think there was some confusion and a little bit of denial.
Okay, thank you very much. Dr. Ruth Muhindo is asking in the chat what mode of delivery was employed. I think you mentioned the chat, but if you could just reiterate for her clarity.
Oh, so the baby was delivered, had a spontaneous vertex delivery. Yes, with the consultation of the obstetricians, there was no indication for a C-section. So we augmented we ripened the cervix and augmented labor with oxytocin, and were able to deliver a live baby boy.
Thank you very much. Another question from Bernard Oyang is, while this baby was still in utero, were there any specific resuscitation interventions directed towards the baby? How was the baby resuscitated in utero? What measures for resus were instituted for the fetus?
Okay, so of course the fetus is okay. The placenta is very similar to the brain, so most of the measures that are instituted to protect the brain are instituted to protect the fetus. So it was largely preventing hypoxia, preventing hypotension, and maintaining nutrition and fluid resuscitation. That was basically it. But the physiologies are basically the same. So all the things you do to protect the brain would be the similar things you do to protect the placenta. So we basically prevented hypotension, prevented hypoxia, and nutrition.
Okay, thank you. And then the other question comes from Dr. Semei, again on the chat. Is asking about induction of labor and increased ICP relationship. Dr. Semei, if you could unmute and just ask your question clearly, because you just put in nice big words there, but I don't know how to connect this into a good question. Dr. Semei, please.
Thank you so much. My question is, in this patient whom we already knew that already we had an increased ICP, could the augmentation probably have further increase the ICP, especially in this setting where we're unable to monitor the ICP objectively?
Okay, over to Dr. Joyce, please.
I'm not sure how to accurately answer that question or answer the question correctly. I guess from just biological plausibility, I would say yes. I guess if you have during labor there would be some increment in ICP. But based off the state of this patient, for the fact that they had a GCS of about 3 out of 15, I'm not so sure about proprioception. I'm not sure I have the answer to that question. Whether I guess what you're trying to say is the process of labor in itself increases ICP. So if you have a patient with ICP, then you're better off choosing a C-section as a modality of delivering the baby. I don't have a right answer. Maybe some of my colleagues can help.
Perhaps maybe to ask is, was the decision to deliver this baby made before or after you had confirmed that the lady is brain dead?
So when the lady came in, I would say the lady came in convulsing, and later on we noted that they had a respiratory arrest. So when we put all the symptoms together, the hypertension, the pupils, the respiratory arrest, we definitely thought that the patient had severe intracranial hypertension and was at high risk of coning. At that point, our discussion with and when we examined the patient, the os was still closed. So the priority at that point, based off the obstetricians, went to the mother, trying to do interventions that could improve the mother's status. So we were told to first do investigations, find out what's going on, and then whether we agreed, we were told to do investigations, find out what's going on, and then discuss with the neurosurgical team. So to briefly answer your question, the diagnosis of brain death was, or the suspicion of brain death occurred first before, the rest. So after we had confirmed that we're not going to do any surgical intervention, then the next thing was, let's deliver the baby and go forward.
Okay, thank you. So in other words, you did this procedure now to save the baby after you were sure that the mother was not salvageable, which kind of helps because I guess the question Dr. Mutesasira is asking on the side is that when you deliver a baby, you're also going to give oxytocics, which are going to kind of self-transfuse, auto-transfuse the mother with, over a liter, half a liter of blood, and that expansion of volume could definitely affect a person who has got raised ICP with active bleeding. And so the order of intervention, sometimes such mothers, if you're also saving the mother, would be to start with neurosurgical intervention, take out the bleed and so on, before you go for the obstetric procedure. But I guess it didn't matter in this case, given that the mother was already determined to be brain dead. I'm just going to run through the few questions quickly, and maybe you can respond to them together. Joyce, if you could just write the okay on the chat. So Dr. Peter Agaba wishes to know what the patient's neurological exam on admission was. He kind of missed it. And then Dr. Cornelius is asking if the diagnosis of brain death was only made on clinical criteria, and if there were any limitations you might have identified with the clinical criteria, and therefore whether you did any ancillary tests.
So the clinical examination on admission, like we emphasize at first, the patient comes in convulsing. The generalized tonic convulsion lasts about 30 seconds. Then when on examination of the patient neurologically, the GCS was about 3 out of 15, with pupils about 4 millimeters, non-reactive bilaterally, and the patient had no cough, no gag reflex, no corneal reflex, and no oculocephalic reflex on admission. In fact, they were intubated without any sort of drug given. I think that was the first question. The next question was the diagnosis of brain death, whether it was largely clinical or whether there were any ancillary tests and whether we faced any limitation. Yes, of course, there was a clinical diagnosis, like we have seen. We did brain CT scan to find out what could have been the cause of the neurological situation. Would have preferred maybe to do a CT angiogram and probably an EEG. An EEG would have helped us to rule out a non-convulsive status epilepticus as well. We couldn't do that. And probably a CT angiogram as well would have been helpful.
All right, thank you. And I guess the final question for this session before we move on to the next one is what was the Apgar score for the baby? And maybe just as a bonus, what was the reason the neurosurgeons were called in? Just as a bonus.
Okay, so when we according to the brain CT scan, there was an intraventricular bleed that was found in. It involved the lateral ventricles and the fourth ventricle as well. There were also signs of acute obstructive ventriculomegaly. So we thought that the neurosurgeon could perform maybe insert an EVD or do a decompression. So help us to manage the ICP in conclusion. Yeah, that's why the neurosurgeon was called in. The other question was, I've forgotten, Dr. Asiimwe.
The question was on the Apgar score. The Apgar
score was 5 and 7. 5 and 7.
Okay, sorry, I might have missed, Doctor. The timelines, a patient arriving, disease diagnosis of brain death, and then the delivery of baby. Sorry, I missed that.
So the patient on day 1 arrived around 15:00 hours. They are taken to the ICU around, okay, they were in the emergency room, of course, at first. They are taken to the ICU at around maybe 19:00 hours. They are reviewed by the neurosurgeon at 22:00 hours. The baby is delivered. So at of course there were repeated neurological examinations, and at all those points there was consistency in the neurological examination. This patient was not sedated. For any reason, given sedatives were just connected to the mechanical ventilator. The baby was delivered on day 2 at 8 a.m. and the family conference was held at around 12 p.m. and that's when the vasopressors were withdrawn, and the patient got a cardiac arrest at around 2:30 p.m. on day 2.
All right, thank you very much, Dr. Joyce. We can keep going back and forth on the case, which was quite nicely presented and definitely quite enriching and representative of our environment. But going forward, could you respond to some of the questions in the chat, perhaps, so that the rest of people asking on the chat can get the answers they seek for? I'd like to move forward. So Dr. Cornelius, I'd like to run another poll question before we welcome the next presenter. Thank you.
All right, thank you, Dr. Asmas. That was interesting discussion. So the next poll will be about just before the next session, which is going to be about physiology. So just to get a bit of background, which cranial nerves are responsible for pupillary reflex? We shall take about a minute. Joyce mentioned the assessed cranial nerves in the patient that she had. And those cranial nerves reflexes are what we are going to look at, and hopefully at the end of the discussion we shall have some bit of understanding. So we shall take about an extra 30 seconds. Okay, 10 seconds left to the end of the poll. Okay, so that's the end of the poll. So I'll share the results. So which cranial nerves are responsible for pupillary reflexes? Optic oculomotor had 72% selection compared to trigeminal facial nerves and only optic. All right, and then the next poll question will be about, again, physiology. And here it is. Again, we shall take about a minute. So which cranial nerves are responsible for the corneal reflex? Which cranial nerves are responsible for the cranial reflex? So Dr. Claire Baaka, please note the questions, and then we shall just have, if you don't answer them during the talk, we shall have your responses at the end. Okay, we have about 15 seconds left to the end of the poll. Okay, 5 seconds to the end. All right, that's the end of the poll. So which cranial nerves are responsible for the corneal reflex? We have a tie between trigeminal and facial, and oculomotor and facial. All right, and then the final poll on physiology is going to be regarding the caloric test. So the caloric test is more powerful than the oculocephalic test. Is it true or is it false? Okay, so for those of you who responded, I think we had a majority of the audience that has diagnosed brain death. This should be fairly easy questions for you now. Before Dr. Claire, the rest of the audience that was not has not done this, I think they're already picking up some of the learning. So we have about 5 seconds now to the end of this poll, and then we shall have a discussion. Okay, that's the end of the poll. The results are in, and we have a majority saying this is a false statement. So let's listen to Dr. Claire Baaka. Dr. Erasmus, over to you to introduce Dr. Claire. Thank you.
Thank you very much to team for the participation. Let's keep getting your opinions in these polls. It helps to understand where we need to pay attention, and the presenters definitely know where to pay a lot of attention when they are presenting. So yeah, next presentation is going to be taking us into and give us an understanding of how this whole condition comes about. So we are going to have Dr. Claire Baaka, again, an anesthesiologist and scale fellow for critical care medicine. She will be taking us through the pathophysiology of brainstem death. So over to you, Dr. Claire.
Thank you, Dr. Erasmus. Thank every one of you for having logged in to listen to this presentation. Am I audible? Can you all hear me?
You are audible, but I wish you could get closer to your microphone because it sounds like the room is absorbing a bit of the sound.
Is that better?
Yes, that's much better.
Okay, thank you. Okay, so I'm going to talk about the pathophysiology of brainstem death briefly. We'll start off with the physiology and anatomy of the brainstem. So what we have right there is partly your brainstem and also the cerebellum and the cerebrum. So we have what is in pink right there is the reticular formation. So this is responsible for alertness and arousal in humans. And basically, it's located in the brainstem. It connects to the higher cortical areas of the brain. In the presentations to come, they'll talk about why it's important to, first of all,
Dr. Claire, sorry to interrupt.
assess for.
The network connectivity is a little bit poor. I don't know if there's anything you can do to just get a seamless connection.
Dr. Erasmus, can I?
Yeah, it is breaking. It's breaking as you speak. Could you just, if you could just move to clearer location as we just wait a moment.
Dr. Erasmus, probably you can give me feedback after like 2 more minutes. If this is not stable, I may have to find another internet connection.
Claire?
So
Yeah.
I was again, yes.
Yes, feel free to email me your slides, and then I can do it from this side because the window may be difficult for you.
Thanks.
Yeah. Or you can just drop it in my just DM it to me on the chat room, and then I'll get it. I'll download it and use it from here.
Right.
Yeah, you can just drop it in the chat room. I'll see it. Claire, you can proceed. It's all right. Thank you.
Okay, I think let me just, I failed to drop it there, but it's on your Gmail. Okay, so we can continue. So we measured the brainstem contains the reticular system. So it's where the origin of the cranial nerves that we're going to mention later on are, and as well in the medulla, but we have the pneumatic center in the pons. Yeah, so it's important to. Okay, so this next diagram shows different cranial nerves, and clearly, as you can see in the midbrain, we have the cranial nerve 2 and cranial nerve 3, and those tests that the right reflex. Can you hear me?
Yes, proceed. Thank you.
Okay, and in the pons, we have 4 cranial nerves, that is cranial nerve 5, 6, 7, and 8. And cranial nerve 5 and 7 test for the corneal reflex, while 8 and 3 test for the caloric reflex. The last 4 cranial nerves are found in the medulla, and that's of which 9 and 11, 9 and 10 test
Dr. Claire. Erasmus, can you hear her?
No, so the connectivity is quite really poor on Dr. Claire's side. Dr. Claire.
The dying brain. So what happened?
Dr. Claire, sorry to
Neurovascular coupling.
again.
And this transmission and yes.
Dr. Claire, unfortunately, again, your connectivity is quite poor.
Okay, let me share from my side, and then we see if the connectivity will be fine. Is that okay with you? Hello? Hello, Claire. Can I share from my side, and then we'll see if it will be okay from your side? Okay.
Yes, Dr. Cornell.
Okay, let me do that. Okay. So these are your slides. This is, I think, where you are. So you just want me to skip in case you want me to skip. Thank you.
Now? Okay, so on the very first slide, we have a neurovascular coupling. And when you have neural activation, this usually leads to increased blood supply to the brain. Usually this is a basis of so neuronal injury, there's disruption of the neurovascular coupling, and we shall see what really happens. The second image, that graph shows the reduction in cerebral blood flow and the effects of the decreased flow to the vital brain functions. So normal cerebral blood flow is 55 mils per minute per 100 grams of brain tissue. But as the blood flow drops, there are certain metabolic consequences. Usually inhibition of protein synthesis begins at about 50 mils, and with further dropping, as you can see below 35, you're going to have your glucose utilization of the neuronal cells increasing. Below 25, they switch to anaerobic glycolysis, and that's where you have lactate formation and tissue acidosis. Below 17, we have neuronal electrical failure. In other words, your sodium potassium pumps fail, and then eventually the membrane failure and cell death. Next slide, Dr. Cornell. Yeah, so we're going to just go through briefly the mechanism of neuronal death. So usually when you have ischemia, and again, this could be from TBI, it could be from hypoxia, post-cardiac arrest, or it could also be from a tissue, a lesion or a tumor that's compressing onto there's a reduction in glucose and ATP that's available for the neural cells. And so this leads to sodium, potassium, ATPase pump failure. And when that fails, we have sodium instead staying inside the cells and making it more active. And sodium is followed by water, and that results in cell swelling. On the other hand, we also have excitotoxicity. So when you have a sodium potassium pump failure, the neurotransmitters and the neurotransmitter uptake by the cells is reduced. So they basically stay outside the cells and exciting neural cells and also nearby neural cells. And the process, so you have basically overactivation of glutamate receptors by the neurotransmitter glutamate. And this triggers excessive influx of calcium ions into the ischemic cells. And this leads to the whole process of mitochondrial dysfunction. But also you have production of reactive oxygen species, which also lead to DNA damage. And so those both processes, mitochondrial damage, DNA damage, basically lead to apoptosis eventually. So the end result of ischemia is cell death, but also swelling. And you have also, when neural cells die, there's also release of excess glutamates, which excites other neuronal cells. So the process, the cascade continues with, and so that means you have massive cell death just from, from the whole process. Yeah, so we move to the next slide. Okay, so okay, thank you. I'm not able to see my slide. Okay, so again, like I said, we have massive cerebral edema from cells swelling, and this edema increases intracranial pressure, and this will further cause herniation of the brain stem. And this usually the herniation is via the foramen magnum. And this also causes further arterial occlusion and compression, yeah, with the advancing brain ischemia. So that's what brings us to progressive brainstem ischemia in the craniocaudal fashion. So it's from up to down. And as the pons become ischemic, important to note that in the pons, the upper part contains the parasympathetic nuclei, and lower it's more of sympathetic, as you can see from the diagram. Yeah, so there's a nucleus ambiguous, which is from which the dorsal motor nuclei of the vagus exits. But in the caudal aspect, just lower, you have more of the rostroventrolateral medulla is where you have your sympathetic nervous system nuclei. So what happens initially, you have when the pons become ischemic, the sympathetic nervous system is activated, because so we have, because already we are switching off the parasympathetic nervous system before, again, like we said, from the craniocaudal fashion. So there's first switching off of the parasympathetic nervous system, and later on we have the sympathetic system taking over. And this leads to excessive sympathetic activation, which causes tachycardia, vasoconstriction, and pupillary dilatation. But 15 minutes after brain death, around 15 minutes, we have ischemia basically of the brainstem, and also the sympathetic stimulation stops. And this is followed by the vasoplegic hypotension, which usually requires very high doses of vasopressors to maintain the blood pressure. And next slide. Yeah, so the other result of a brain death is in health, basically, you have when you have inflammation, there's production of cytokines and other interleukins. That's interleukin 1 beta, and these cytokines interact with the nucleus structus solitus, and this activation of the parasympathetic usually switches off the inflammation. So the parasympathetic nervous system itself ideally regulates inflammation. So it's a whole process, leads to inhibition of pro-inflammatory cytokines. However, in brain death, the parasympathetic nervous system now leads to an unchecked production of macrophages, and this activates the immune system. On the other hand, in health, the sympathetic nervous system ideally is pro-inflammatory. So which leads to, so when there is the result of sympathetic, again, like we've said, sympathetic nervous system takes over, it leads to continued, it needs to be T and B cell lymphocyte proliferation, and this further drives the inflammatory cascade. So it's important to note that inflammation generally happens. Systemic inflammation actually happens after brainstem death. Next slide. Okay, so, and what happens in the coagulation? Normally your Wilberforce factor and the Adam TS13, but in brainstem death, there's increased sympathetic activation, and this leads to excessive activation of the endothelium, which increases expression of the von Willebrand factor propeptide. So ideally, this von Willebrand factor supersedes the Adam TS13 levels, and this also results in thrombotic state. But there's also excessive activation of the immune system through the tumor necrotic factor, which leads to activation of monocytes that produce the tissue factor. And the tissue factor then activates the extrinsic coagulation pathway via the clotting factors. So this leads to clot formation. And so basically you have a thrombotic state after brain death. Next slide. So the cardiovascular system, so there's been incidents of, research has shown that there's about 50 to 90% of occurrence of myocardial dysfunction following brain injury. But there are two mechanisms, mechanisms that explain this. There's the catecholamine storm that enhances the beta-adrenergic stimulation, which leads to coronary vasoconstriction, which leads to ischemia and also arrhythmias. However, there's also another hypothesis, which is called it's the Nowitzki hypothesis. So I think you can go and read up on those two hypotheses that eventually lead to cardiovascular dysfunction. Next slide. Yes, and so in the pulmonary system, like we've said, the catecholamine storm leads to massive rise of pulmonary capillary pressure, and this leads to alveolar. So we have a massive rise in the pulmonary capillary pressure, and also capillary permeability increases, and this increases protein and fluid flux across the capillary endothelium. And so this is what explains the pulmonary edema. But also we mentioned that the B and T cell proliferation happens. And so this the humoral and cellular pathways
I think we have lost Dr. Claire. We can give her a few seconds to return. Dr. Claire, please.
Can you hear me now?
Yes, we can. Thank you. Claire, please proceed.
Can you hear me now?
Yes, we can hear you. Claire, please proceed.
Cornell, I think my internet went off. I'm just requesting you to let me know if you can hear me.
We can hear you. We can hear you.
We can hear you loud and clear.
Just continue, Claire. Claire, please unmute yourself and proceed.
Okay. I apologize. So we're still talking about the pulmonary system. So we mentioned that I mentioned that the catecholamine storm basically leads to increased pulmonary capillary pressure, and also there is alteration of the capillary permeability, which causes increased protein and fluid efflux, which causes eventually pulmonary edema. But there's also increased, like mentioned, inflammatory cells, cytokine upregulation, which then leads to tissue damage as well. Next slide. So the endocrine system, this post-brain death or brain stem death, initially you have the hypothalamic pituitary axis being cessation of that axis. So most of the hormones that arise from that axis are the ones that affect the whole system. So initially you have rapid depletion of ADH, and this causes diabetes insipidus, and this has been observed in 80% of all brain death donors. This usually leads to inappropriate diuresis, and so it leads to a hypovolemia, hyperosmolarity, and also hypernatremia. On the other hand, there's thyroid dysfunction, but what was known as non-thyroidal illness. Apparently, the thyroid hormone levels don't actually drop, but they've noticed that T3 concentrations fall to approximately 50% of the normal within 24 hours of brain death. And so important to know that they may need to give thyroxine hormone to those patients that are organ donors. Also, insulin levels have usually drop in brain death, and this leads to hyperglycemia. This usually is from the catecholamine storm. It's cortisol per se does not exactly drop. Apparently, it's still controversial. It stays normal in some patients, and others it's upregulated. But important also mention that dopamine, noradrenaline, and adrenaline levels shoot up initially for like 15 minutes after brain death, and then that's catecholamine storm subsides. Yeah, and however, the dopamine levels stay elevated for apparently up to 90 minutes. Yeah, so the other aspect of hormonal aspect is the female sex hormones. Apparently, in normal life, they are important in regulating white cell subpopulations, and they also delay neutrophil apoptosis. And that's why females have a better outcome than males after shock, trauma, and sepsis. However, since they're also cut off, so we expect that the SARS, that the inflammatory process is prolonged, and therefore, in patients who are organ donors, then it should be considered. Go to the next slide. So in summary, from the left side, when we have increased ICP as a result of ischemia and all those cellular mechanisms, cell swelling, we initially have a Cushing response. And remember, when you have increased ICP, you have basically your body compensates by increasing the MAP, but to some extent they can again continue getting brain edema, brain and increased ICP. So there's like a cutoff of cerebral blood flow completely. Yeah, and so whenever you have ischemia, thank you, ischemia, then the whole cascade of cell death happens, and sorry, okay. I'm sorry, I just couldn't find my slide. Yeah, so so you have cell death, but remember that ischemia is also driving the sympathetic storm after the pons after you get ischemic death of the pons. So this sympathetic storm has effects on different organs of the body, right from your lungs. We have alveolar epithelial cell damage and pulmonary edema, and this and alveolar barrier disruption. This further worsens. Of course, there's release of cytokines, so it causes inflammation in the whole body, the rest of the organs. There's neuronal damaged ischemia, and then this leads to, of course, progression of brain edema, increased ICP. So it's really a vicious cycle. Also, the sympathetic storm, remember, causes cardiovascular dysfunction. So this really summarizes what we talked about. Thanks for listening.
All right, thank you very much, Dr. Claire, for packing it all in. We're discussing brain death and definitely understanding the pathophysiology, especially its nitty-gritty detail, is helpful. It's sad, of course, that we've had a bit of network connectivity, and some people have some questions that have been posted in the chat, which I'll be sharing with you in a bit. So the first question, Dr. Claire, really just requests you to the Dr. Cornelius is asking what the rationale of an atropine test is to diagnose of brain death, and if you'd recommend it for clinical diagnosis.
Can you hear me? Dr.
Yes,
Rahman?
Dr. Claire, I can hear you.
Okay. The question was, could you please help repeat the question?
So the question is, what's the rationale behind the atropine test in brain death, and is it a recommended test for clinical diagnosis?
Okay. So I'll start with, okay, so the atropine test per se, if you administer atropine, ideally it should, it's the vagal, so basically you have the parasympathetic and switched off right from your brainstem. So I think it's patchy information, but what I think is since you have your parasympathetic nerve fibers, okay, like right from the brainstem to the heart, like sort of part of, I don't think that atropine is actually going to induce any effect, and so yeah, it would be used for diagnosis of brain death, because then yeah, it should confirm that that pathway is cut off. I don't know if someone else has a better explanation.
Okay, thank you so much, Dr. Claire, for your response. I don't know if Dr. Cornelius, did you, what would be your thoughts, perhaps, just to bring the conversion back to the specialist level?
Yeah, yeah, thank you, Dr. Rasmus. I think there was there are quite a number of scenarios in which the atropine test may give you an idea, especially when you can't complete your tests, but it is not really recommended. But like Claire mentioned, the origin of these cranial nerves is mostly from the brain stem, and so the vagus nerve that is primarily responsible for transmitting these parasympathetic impulses to the heart, and therefore causing, if I increase discharge from the vagus nerve, I should be able to cause bradycardia in a patient. If I shut off the parasympathetics, it means I should see a surge in the sympathetic drive, and so the heart rate should go up. And what you sometimes will see when you give atropine in patients who are brain dead, you don't see a response. You don't see an increase in the, if they have a tachycardia, you still will not see any particular rise of more than 10 to 20%. And that may give you an idea that perhaps that is there is brain death, but it is not a very good test to use, because there are so many confounders related to that, including the possibility that this patient may have been on medication that actually slows down the heart. So it's not a very reliable test, but in our setting, like where we are, it could be something you could add, but in terms of international consensus, it's not. Yeah.
All right, thank you very much, Cornelius. I guess just to add on that, I do agree. Of course, it's a limited setting in terms of resources, and we are going to have a talk next about diagnosis of brain death, and we shall probably hear from the next speaker, and maybe be able to pose some questions on what his thoughts might be on what else we could do in our limited setting. Technically, I would say that if you're running an ICU, you should probably be able to do quite a bit in terms of brain death declaration, and hopefully we shall get to know a lot more about how it's done. But basically, atropine test, the heart rate variability with respiration, among other things, are really some of those small clues that give you that sweet, that kind of feeling, or a sweet or bad feeling that your patient may not necessarily be in the house anymore, and maybe helps with the conversation, the prognostication, among other things. So we will get to know a lot more about this, and I hope that the next speaker is listening in and will pay a bit of homage to some of these crude tests that we might be able to use to just get more information. Do we have any other questions relevant to the presentation of Dr. Claire?
I think Dr. Fred Ulamba made a comment. In summary, everything fails in the body, and I think that is true. I think from some of the experiences, maybe some can share theirs. It's almost, when a patient is in the ICU, regardless of whether everything looks fine, there is a certain feel that you get that this patient is no longer with us. But within a very limited time, you start to struggle to keep them alive. All of a sudden, their pressures are crashing, and you're going up on doses of AP or norepinephrine, whatever you're using. Mostly, it's the cardiovascular system that starts to crash, and it's literally, it becomes a burden to actually keep them going. So it's quite an ominous look for most of the patients once they're brain dead. You can literally feel that this patient is no longer with us. But of course, that is extremely subjective, as we shall see from the next presentation. Over to you, Erasmus.
Yes, perhaps again, I like the back and forth, and Dr. Claire, please stay with us. I guess the next question is, given this autonomic dysfunction that we see with the crazy, sympathetic storms, and then eventually the crash in hemodynamics and so on, just bring it down to the choice of, medication for hemodynamic support. What would your thoughts be, Claire? First, and then maybe Cornelius, regarding how to support the hemodynamics in this case. This is a guy who's probably getting into shock. Let's first start with what you want to do maybe when the patient's getting hypertensive. They shoot up BPs of 200 over 140 or something like that, heart rates of 220, crazy high stuff. And then eventually they got down to, the flow with all the drops in BPs, heart rates crashing, among other things. What would the choice of support be for these patients? Perhaps, Dr. Claire, would you have some thoughts to share with us on maybe, given the physiology and the pathology you've just shared, what would probably make sense? I know that
I think also Joyce, since she had a clinical case that she went through, can tell us her thoughts on this.
Yeah, true. Yeah. And maybe how easy it was to achieve hemodynamic stability, with the choices that they used. Dr. Joyce, maybe starting with you from your case. Did you have any hypertensive episodes? Did you have hypotensive episodes? And how did you handle them in this patient?
Okay, thank you, Dr. Erasmus. So when the patient presented at a presentation, they were hypertensive, but that quickly, and then after a few, maybe 5-10 minutes, they were hypotensive. So based off, I think, Claire's pathophysiology, what she has presented, she has described a period of a catecholamine storm where you have an elevation in both, in all the three, which is dopamine, adrenaline, and noradrenaline. And I think she said the dopamine surge lasts about an hour, but then that quickly comes down. So considering the vasopressor of choice, Of course, in this case, we went with noradrenaline as first line. But of course, as the patient gets worse and as the hours pass on, you keep increasing the dose of noradrenaline, and in most cases, you have to add another. Usually adrenaline is what we add. I'm not so sure if adrenaline, if noradrenaline would perform better than adrenaline. Maybe if the patient is having bradycardias as well, adrenaline could be a better choice as compared to noradrenaline. I think those are my thoughts.
All right. Yeah. Claire, any thoughts? Yeah.
Claire, muted.
Claire may be struggling with the high intent again. Maybe Dr. Cornelius, you could just take this on. Yeah.
Yeah, so I mean, at the point at which we often diagnose brain death, the usual, of course, the situation where patients, it's quite rapid, and you can't, sometimes you don't actually see it coming. And so in most instances, you want to resuscitate them with I mean, epinephrine would be a fairly good agent. However, norepinephrine would still do the same job. Perhaps the biggest challenge is going to be, especially if their blood pressures are plummeting downwards, you're going to end up probably using 2 vasopressors to just sustain them. And that means, personally, at that point, I really don't care which vasopressor I'm using. At that point, it's going to be guided by whatever clinical parameters I'm having and what I need to stabilize to give me time to have a chat with the family. And so in most instances, if it's going to be noradrenaline, of course, your heart rates tend to drop pretty low at the same time, because noradrenaline is not as a powerful beta-1 stimulant as adrenaline. So in most instances, adrenaline would actually be helpful in sustaining that. But with a sympathetic storm that you have initially, you end up, it all seems to die down, especially when you start to see your pressures, the requirement going pretty high up. So I really cannot point to any particular pressor of choice at this point. I think I would mostly be guided by what targets I need to meet to give me time to have a chat with the family, and also give a chance to reversing all potential confounders that may exist, that may actually be the reason as why the patient is the way they are. So yeah, that's probably what I would do. Dr. Rasmus, what's your experience?
Yes, Claire, go ahead.
Yeah.
Okay, Dr. Rasmus, what I also, maybe to add on what Cornel has said, and I actually also agree with Cornel. I think you can still use noradrenaline, you can use adrenaline as well. But well, at a point where you have severe vasoplegia, you even have, you have diabetes insipidus, and your requirements go very, very high. Again, you can combine the two, but also remember there's lactic acidosis because of hypoperfusion. So they tend to eventually end up very bad acidosis.
Dr. Claire, you muted before you completed your comment, making a comment. Dr. Cornelius, I share the same, opinions, and I guess my practice was around that. But my question has always been around the concern that, this sympathetic storm hyperstimulates receptors across the vasculature and the myocardium, and then you've got, different grades of desensitization. So part of the vasoplegia, part of the hypotension really is down to a cardiogenic kind of shock, which tends to be driven, at least when I do echoes on most of these patients, I find it's like a Pathophysiology, which is a broken heart, where you have part of the heart is contracted and part of it is not. And the more you use adrenaline on them, the more they fail further, which is because the real mechanism for the heart failing to do its job is particularly driven by sympathetic stimulation. So I guess the question I was asking really is just hypothetical. Well, I currently have, I would say, 1 to 2 patients in whom I'm fighting these autonomic wars, and so far winning. But the question is whether this is the case where I want to think about alternative vessel, inotropes and vasopressors, unlike outside the catecholamine range. So I'm thinking about, where feasible, using things like milrinone, of course, levosimendan would be great. Using things like, vasopressin in some of these patients, just to cut down the sympathetic, so the catecholamine use in resuscitation, which seemingly would further the need, the injury that's not coming from catecholamine stimulation. I see that these patients tend to have quite significant vasoconstriction, which means somehow in the systemic circulation they're getting the constriction they need, but they are hypotensive. When you scan them, you find the heart is the one that is really not doing a good job. And the more NORAD you give them, the more vasoconstriction you get, but the cardiac output doesn't really seem to do a very good job during that time, and which is expected. And definitely when you go to adrenaline as well, you might get a bit of a kick. First of all, you get a bit of bang for your buck, but then unfortunately over time they seem to deteriorate further. So just thinking hypothetically whether this would be kind of cases where I want to try alternatives. So currently, patients I have, I'm actually using vasopressin. I'm trying to use as a primary vasopressor, although the dose limitations vasopressin mean that I still have to use the catecholamines on top of it. I've had to add in steroids. I've had to add in calcium, to support the patients. And then there are always those moments when there is loss of, the storm and everything crashes. Then you have to fight back, among other things. And maybe I guess the big question here, and maybe back to Dr. Claire, is that when these guys get that storm of hypertension and tachycardia, to me, it sounds like that's really when the patient's herniating. They're getting pressure on the vasomotor center. And so the increase in BP, the increase in heart rate really seems to signify that, the brain's under pressure. And so the temptation is to grab something to drop the BPs. I don't know what your thoughts are in that situation. The patient's BP is like 200 over 120, 140. I don't know. Cornell, this is not really going to be evidence-based. I just want to hear your thoughts on what you would do in that situation.
Yeah, right. I think for the first, relating to what your hypothesis is, and maybe Peter can also weigh in on this one. I really do not see. I don't try to break my mind over winning the battle, because the battle is lost at that point when you diagnose brain death, and at that point the goal simply becomes me keeping the patient alive for the vitals stable, not alive, vitals stable enough for me to have a chat with the family, and that becomes the goal. That the idea that milrinone is a pretty costly drug. An ampule is like 250,000. If you get a good supplier, I don't know how much vasopressin costs that patient, but I think at the point at which you have a patient who is brain dead, and I understand the aspects of Takotsubo. If I can simply barely keep them, those vitals stable enough for me to have a chat with the family, I would definitely pick that without necessarily increasing the cost of care for the patient in that regard. Of course, if I'm in a scenario where I have all the resources I need, definitely, I do believe in the idea that for any patient who is hypotensive or who suddenly becomes hypotensive, it is important for you to put a probe on the heart and let that guide you also in terms of the selection of inotropes and vasopressors. Other than that, I think it would be quite interesting to see if improving the Takotsubo would actually have any impact on survival. which you can argue that it won't.
Maybe the comment was kind of misplaced. What happens is that all the changes we are seeing in the pathophysiology seem to be happening in the process leading up to brain death. So you have a patient with a raised ICP, progression, potential progression to brain death, and maybe you're doing some intervention that period. They're going to be having hypertensive episodes and so on. And eventually, of course, everything crashes, as Dr. Fred mentioned. And at that point, you're now very clear that the outcome is very certain, and there's not going to be a lot of dancing to do. So now vasopressin, I guess, as a specific for the question you asked, vasopressin is relatively cheap, surprisingly. I think a vial is going for about 30,000. And usually, from the studies in sepsis for vasopressin, they require about, for an adult, about a fixed dose of about 0.03 to 0.04 units per minute. And that means 2 ampules, that's about 60,000, should be able to run your patient for over 24 hours. And that is going to be significantly lower than the dose you're going to probably need for norepi and epi. But again, my experience too, it's not really going to take away the need for the others. So it's more of a cost-cutting intervention, just to introduce another vasopressor to reduce the requirements for the others during that period when you need to sustain the patient as you wait for the decisions to be taken. We've taken quite a long time on this part of the chat, so I'll just go to the chat quickly to grab a few questions before we take
a comment.
Yes, sir?
Dr. Agre has a comment.
Oh, yes, Dr. Agre, please make your comment, sir. Dr. Agre, please unmute and speak. Your hand is up. Okay.
Agre, unmute. I think he's unmuted.
Yes, can you hear me now?
Yes, we can hear you, sir.
Thank you so much, everyone, for the presentation, and especially the modulators. I'll share just experiences that I saw when we were doing the fellowship. India does a lot of transplants, and they use a lot of cadaveric transplants. Literally, every patient dies, there'll be a clinical psychologist to come in and a sociologist to come and try and talk to the family. They've kind of, for them, they enhance the process. But there is also a fund that has been generated within the donation organization or the Council of Organ Transplants, that every patient that agrees to donate their organs, or the relatives that agree, they would have to maintain or kind of preserve that body within 3 to 7 days. So the use of vasopressors was quite very noted, and typically they would use normal adrenaline, noradrenaline, and vasopressin. And for the year I was there, I never saw anyone use an Nemileron, but at least the 3 seem to have worked very effectively well, and actually we to preserve patients up to 7 days until every hospital has enlisted that wishes to receive an organ, and the council decides who to receive. So I think without stretching ourselves, the 3 still are very, very effective, as long as we predict and we prevent further collapse and support other organs in time. And also steroid use is also very commonly noted, and fluid supplementation. Those are my sharing. Thank you.
Okay, thank you so much, Dr. Gray. Dr. Fiona is asking, what do you term as death to the family? Is it a brain stop? Is it a brain or the stopping of the heart? Dr. Fiona, we shall answer this question after the next presentation, if you don't mind. And then the next question again from Dr. Fiona is, she missed a comment on, oh, sorry, it's the same question. And Dr. Seme is asking, what's the state of adrenergic receptors in terms of responsiveness? Because I would think that maybe after the sympathetic surge, I think this has been answered, Dr. Seme. So without spending a lot more time here, I would just like us to take a bit of a break and just handle a bit of a poll here. So Dr. Cornelius, over to you.
Thank you, Erasmus. So let's proceed with the poll question. So without a blood gas analysis, clinical brain death diagnosis can't be made. True or false? Okay, I think up next will be answering some of these questions, and then we may not provide you a chance to change your answers. So give your answers as soon as you see the poll. Okay, we have 5 seconds to the end of the poll. Okay, so I'll end the poll here. So these are the results. So without blood gas analysis, clinical brain death diagnosis can't be made. We are going to see the next poll. So the next one again is going to be about diagnosis. And this is the one. So brain death cannot be diagnosed without brain imaging tests like EEG and brain perfusion scans. True or false? Okay, 30 seconds left to the end of the poll. I think once we have more than half of the audience, I will close the poll. I think that should be fairly representative of the audience. We have about 15 seconds left. Okay, this is the end of that poll. And so brain death cannot be diagnosed without, a majority of you said false. We shall find out if that is true. And then the next question, again about diagnosis, is here. What prerequisite must be met before brain death diagnostic testing is performed? You can select all that apply. So you don't have to select only one option. Select all that apply. Okay. Again, I will close the poll when more than half of the audience has responded. Otherwise, we have 10 seconds, about 5, 4, 3, 2, 1. So I'll end the poll, and these are the results. The prerequisites, the 80% of the audience says there must be a known cause or evidence of catastrophic irreversible brain injury, and then absent confounders. And then 29%, a small fraction, said family consent is important. Okay, and then the final question on diagnosis is here. Of these tests, which one is the gold standard for brain death? The gold standard test for brain death. And hopefully, Dr. Peter Agaba will be able to answer some of the questions that will rise from this. So we have hit more than half of the audience. So I'll end the poll there. Sorry, in case you wanted to respond. These are the results. So about 38% of the audience said EEG is the gold standard, and then cerebral angiogram, and then finally the apnea test. So I will request Dr. Erasmus to introduce Dr. Peter Agaba as I prepare to share his talk.
Okay, thank you so much, Dr. Cornelius, and thanks everyone for participating in the polls. So our next speaker is probably known to many of us, and for those who don't know him, I will definitely try my best to fit in all his credentials. So Dr. Peter Agaba is an anesthesiologist. He's extremely interested in everything to do with the brain. So he participates in neuroanesthesiology, care, and education. He is a lecturer in the Department of Anesthesia, and we'll be taking us through the process of diagnosis of brain death. Over to you, Dr. Peter Agaba.
Okay, what I'll do, Peter shared his pre-recorded session talk, and so I will start it on my side and hope you'll be able to hear it.
Good evening, everyone. Thank you for that rather flattering introduction. I am Dr. Peter Agaba, as already said, and I teach at the university in the Department of Anesthesia, Critical Care, and Emergency Medicine. My task this evening will be to talk about the diagnosis of brain death. You only live once. The statement YOLO is probably best quoted before people make some really stupid decisions. But allow me to present some evidence here that this is not true. In this painting by Rembrandt, you can see Jesus raising Lazarus. These are two people who make this statement false. But the point of this talk today is not really about our life after death, but the determination of death. It's unfortunate that no one did a brainstem death exam for Lazarus, but I can tell you that for a properly done brainstem death, there is no evidence of a patient coming back from that diagnosis. Okay, for the next 20 minutes, we will look at the definitions of death and brain death, and then we will dive straight into the soup of this talk, which is a determination of brain death, and then what follows, the communication to the relatives, and then we'll wind up with the controversies surrounding the determination of brain death. Death, what is it? There are various ways to think about death, and this is a rather controversial topic, because we could look at death in several ways. We could look at it as the death of the whole organism. It could be the ending of life with the cessation of all vital functions and signs. Or we may look at it as an irreversible biological event that consists of permanent cessation of all critical functions of the organism as a whole. And this last way of thinking about it allows for the concept that tissue may continue to live even though the organism as a whole is said to be dead. So death really is a difficult thing to define, and we often focus on the cardiorespiratory idea of death when someone stops breathing and when they have no cardiac function. So this creates a lot of controversy. Now, in terms of medical legal definitions for death, it needs to be quite specific. And in a lot of jurisdictions, the definitions are rather specific. When you look at the Ugandan constitution, it doesn't really spell this out and leaves a lot for us to interpret. And you'll find, because of the way our law is designed, we then have to fall back on common law and case law for the definitions of death for our situation. Now, death is a point in time that may be difficult to determine. Okay, that point when we could say the soul leaves the body. More often than not, what we are witness to is the process of dying. When it starts, when it ends, exact times are difficult to pinpoint, okay? But it may, for example, start with the brain dying, and then cessation of breathing, and then the heart stopping. Or it may start with the heart stopping, then cessation of breathing, and then death of the brain, or cessation of the heart function, and then brain death, and then eventually cessation of breathing. Now, with the developments in technology and science, this is even more difficult, because if your patient stops breathing, we could start them on mechanical ventilation. If their heart stops beating, we could then put them on extracorporeal life support. So it's now even more complex, and now we find we must also determine how we find out whether the brain is no longer functioning. So brain death. Brain death can be thought of as a permanent absence of both cerebral and brain stem function. But first, you would need to think about the brain as the cerebrum. Here, think of it as the ice cream cone, with the icing being the cerebrum and the cone being the brain stem. So when we determine what brain death is really, we are assessing both these two parts. And we can define brain death as irreversible loss of the capacity for consciousness combined with the irreversible loss of brain stem function. Now, should we consider this as equivalent to death? Like I had said earlier on, the point in time is difficult to put your finger on. What we see more often than not are the signs of death, such as cessation of breathing, no pulse, okay, no heart sounds, and a person who is inanimate. So brain death is simply a sign of death and should be considered as equivalent to death. We need to do this to provide closure for families and limit grief. Otherwise, we could keep people's bodies alive for an indefinite amount of time, and we would be giving them care that they don't need and yet is costly. So in order for us to still be able to give these costly resources to people who will benefit, we need to be able to determine when this is no longer needed. And lastly, we also need to be able to facilitate donation of organs that may save another person, that may improve the quality of another life. Determination of brain death involves establishing a cause and then determining that this, or establishing that the brain injury is irreversible, and then excluding any confounders or situations or conditions that may mimic a similar presentation, and then a clinical exam of the brainstem reflexes, and then it concludes with a test for spontaneous respiratory activity from the patient following a carbon dioxide challenge. So more specifically, we must determine certain prerequisites regarding the clinical setting. First, we need to make sure that this patient is in a coma and the cause for this coma is known and is irreversible. We will need imaging that explains the comatose state of the patient, and then the patient must have absent spontaneous respirations, and then we need to exclude any toxins or medications or the clinical states of the patient like hypothermia or major correctable metabolic and endocrine derangements. There are a number of conditions or situations that may present with signs similar to a patient who has brain stem death. For example, hypothermia, low blood pressure, major endocrine abnormalities, acid-base disturbances, or patients who are on paralytics or are sedated or have some illicit drugs. So you will need to ensure that for temperature, your patient's temperature is at least 36, and that they have a systolic blood pressure of no lower than 100 with no major electrolyte or endocrine abnormalities. And you will also want to make sure that they're not on any paralytic agents or sedatives. For these, for the paralytic agents, you will need to do nerve stimulation to ensure that the patient has got no residual neuromuscular blockade. In regards to the sedatives or any opioids that they may be on, you will want to wait at least 5 times the elimination half-life before you can begin to do your assessment for brain death. For example, supposing your patient has been on a thiopentol infusion, maybe they came in with status epilepticus. If you look at thiopentol here, you will see that the elimination half-life is 10 hours. Now, because as you will know with your pharmacology and physiology, the physiological processes usually will take about 5 times the half-life to reach a steady state. That means if you give someone a drug and you wanted that drug to reach a particular level, it will take about 5 times that half-life before you reach a state where what you are giving is equivalent to what the patient is eliminating from their body. Now, the reverse is also true. If you want to eliminate the drug from the body, you will wait about 5 half-lives before you are certain that this drug has been eliminated from the body. So with thiopentol, you would need to wait about 50 hours, which comes to maybe about 2 to maybe 3 days to be certain that it is no longer having an effect on what you see in the patient. Once you have established that there is a cause that is compatible with your diagnosis of brainstem death, and maybe you have done some neuroimaging or from your clinical exam, there is evidence of catastrophic, of acute catastrophic neurological injury. And you have also eliminated confounders, made sure that your patient is hemodynamically stable, normal PCO2, endocrine or metabolic abnormalities. You can then proceed with the physical exam. And this includes us establishing that there is no cerebral function and that there is no brainstem function. The cerebral function involves us in removing the possibility of responses coming from the higher parts of the brain. So we will stimulate the patient with a painful stimulus, preferably supraorbital notch or the mandibular joint or behind the jaw. And there should be no response to pain that we can say originates from the brain. So if your patient is having seizures or they are decerebrated or they have some decorticate posturing, those would disqualify them right away. If, however, they don't have any of those and you have applied some good pressure to these points and there is no response, we can then say, all right, our patient is in a coma, and then we can move on to checking the brain stem reflexes. So commonly, and you will see these being done, these should require little explanation, maybe a few pointers on some of these things. For the pupillary responses, they should be mid position, which is usually going to be about 4 millimeters. Immediately after an ictus or some event, they may be dilated. So you may see anything between 4 millimeters all the way up to maybe even 9 or 7 millimeters. But there should be no response to light. For the corneal responses, if you use a wet piece of cotton, which is kinder to the cornea than a dry one, you just touch the cornea and you should see no response. There should also be an absent oculocephalic and oculovestibular response. For these, we need to take care with this. So for the oculocephalic test, which is the doll's eye test, you will move the patient's head from side to side, but you need to first establish that they do not have any cervical spine injury. So once you have established that, you will then observe for movement of the eyes. The test is considered normal if the patient's eyes move in the opposite direction to the turning of the head, and that is what is called a doll's eye response. If, however, the patient's eyes turn to the side you are moving the head or move with the head, then that test means that is the negative result, which may mean that your patient has some brainstem death. For the caloric test, which is the oculovestibular test, you will use saline, preferably cold. We don't use hot. And it is better to use the ice cold water, about 50 cc's of ice cold water, and you will need to make sure that it reaches the tympanic membrane. So you will want to examine those ears and make sure that there's no obstructions. What the expected response is with a normal brain stem is the eyes will turn to the opposite ear, and you will need to test both ears. Yeah. So once you have done all these tests and each one of them is negative, you can then move on to doing a apneic test. Okay. The caution here is you may see some movements with some patients, but these need to be spinally mediated reflexes. Those are not unusual, but they do not mean that there is any brainstem function. So regarding the apnea test, there is a way to do it. The first step is making sure that your patient is hemodynamically stable. Usually you will want a blood pressure above 100 systolic. The patient should be normocapnic between 35 to 45 millimeters of mercury, and you will pre-oxygenate your patient with 100% inspired oxygen for about 10 minutes. And the target is to get a partial pressure, arterial partial pressure of at least 200 millimeters. You will then maintain oxygenation with a PEEP of 5 centimeters and disconnect your patient from the ventilator, insert a catheter through which you will deliver oxygen. You will drop the catheter to the level of the carina and give about 6 liters of oxygen. The alternative here is to attach a T-piece to the endotracheal tube or the tracheostomy tube and apply a PEEP of about 10 centimeters. And the goal of this is to try and keep your patient oxygenated throughout the test. So you will then observe your patient for about 8 to 10 minutes. And if there's no spontaneous respiration, that is the first stage, the next thing you will do is draw off a blood gas. And if there is a rise in CO2 from the baseline, and if the CO2 is greater or equal to 60 millimeters of mercury, you will then conclude that this test is positive for brainstem death. Okay. The issues here are that, one, if you do have a rise in the partial pressures of carbon dioxide that is greater than 20, but you have an absolute arterial carbon dioxide that is less than 60, you cannot conclude on this test. That test is indeterminate. If you have to stop the test before you can complete the time because your patient is desaturating, if the SATs drop to 85 or below, then you may have to stop the test. Or if your patient becomes hemodynamically unstable, you may then have to stop the test. You could potentially do the test again at another point, support the blood pressure, make sure your patient is well oxygenated, okay? And this may allow you to complete the test. A complete full physical exam is sufficient to make a diagnosis of brain death and is superior to any other test. However, certain patient factors may limit the ability for you to complete the test. And that may mean now you will have to consider some ancillary tests. For example, when you cannot assess all the cranial nerves adequately, or maybe because there is some neuromuscular blockade, or the patient is heavily sedated, or you are unable to complete your apnea test. Or in some states, for example, they require testing for infants who are less than 1 year. You will need some tests and the clinical exam is not accepted. Or for example, in patients who have multiple organ failure or sepsis, for whom elimination of the sedatives and the drugs that you're giving may not be reliable because that function is impaired. So in those instances, you may have to rely on part of the physical exam plus an ancillary test. Now, ancillary tests are not perfect and they come with different problems. So this is what creates a problem in deciding what you need. But the ideal test would be one that you can easily get at the bedside and is cheap and reliable, is not affected by various situations like metabolic problems or electrolyte issues, and will not leave you with false positives. The tests can be grouped into the blood flow tests and the electrophysiologic tests. The blood flow tests, it's taken for granted that if there is no blood flow, then of course that brain is dead. And this really requires no explanation. The cerebral angiography is generally considered the gold standard for these. If, however, you can't get these, the cerebral angiography, then you may go with one of the others. The problem with cerebral angiography is its invasiveness. When it comes to the electrophysiology tests, we've got EEG, and you want to have at least 8 channels before you can rely on what you see. And then you can also do evoked potentials, which include the somatosensory evoked potentials and the brainstem auditory evoked potentials. Some cautions here: if you do use the evoked potentials, your patient should not have a primary lesion in the brainstem. Otherwise, it is no longer reliable. Overall, for the electrophysiological problems, they have got anatomical and physiological limitations. And that is why they probably should not be your go-to. once the diagnosis has been established, then what next? There may be an observation period. You may also have to communicate with the patient, but you will also have to document the results of your test. When it comes to the observation period, this is going to vary. The practice is going to vary based on where in the world you are, but also it's going to vary on the type of patient you have. In general, for adults, patients above 18 years of age, it is sufficient to give them an observation period of about 6 hours, after which you can conclude that your patient is indeed brain dead. But for other patients, for neonates, you may want to wait at least 24 hours. For children less than 1 year, you may be waiting up to 24 hours. And for those between 1 to 18, you will wait up to 12 hours before you can go ahead with your confirming that the patient is indeed brain dead. As regards documentation, remember, you need to clearly document the results of your exam, because these may come back to bite you when there is contention. Important things to note at the time of death, okay, which should probably be recorded at the point at which you do your final blood gas, confirming your apnea test. And in case you do an ancillary test, the time of death can be given at the time you interpret the test. For communication to the patient, this is difficult news to give to any relative, and may also be difficult for health care workers. There are various tools that can help you to structure this, and I will not into those details because I'm out of time. Around the world, the concept of brain death is accepted, but there is variable practice from one country to the next, and even within countries, there is also variability in practice and in the protocols, even from one hospital to the next. This is even worse for us because we have no clear policy on this. And so it's definitely going to create problems for us. The other issue, of course, is the religious, cultural, and the moral perspectives on death, with some religions having, for example, accepting the cardiorespiratory framework of death, and others accepting something else. So having to relay this information or getting your patients to understand what is happening may also be difficult. So in summary, brain death is widely accepted, but there are going to be issues on how it is determined. In this country, the medical fraternity has the job of determining brain death or determining death. It's not the religious leader, it's not the cultural leader, it's not the government, it's the doctor's job. And we need to accept that brain death is the equivalence of cardiorespiratory death. Remember that prior to doing your exam, you must establish that your patient is in a coma with a known cause that is irreversible and can be explained by neuroimaging and a clinical history. Remember to exclude confounders, which may give you false positives when you do your exam. And in general, until a national policy is developed, individual hospitals will have to develop their own protocols to avoid controversy and future litigation. Remember, the clinical exam is the gold standard. A properly done and a complete physical exam is sufficient. Once that is complete, remember there must be clear and effective communication to the relatives. Thank you.
Very nicely.
Thank you very much, Dr. Agaba Peter. I think before Dr. Erasmus comes in, let's go right into the polls, and then we go to Dr. Kabweru, who will talk about the controversies and the ethics related to brain death. So we shall start off with the first question on ethics, and Dr. Agaba initiated this. In your practice, we shall take up to 50% of the audience. In your practice or opinion, who should turn off the ventilator in a patient? If you cannot see the poll question, please go to your phone and tap the More button, and then go to polls and quizzes. It will pop up, and then you will see it. So after 50% of the audience has responded, then we shall close the poll. Again, if you don't see the poll question, go to your, if you're using your phone, go to the button that says More, and then go to polls / quizzes, and you'll be able to respond to the poll. Okay, I think 50% has been reached. So I'll end the poll now and share the results. So a big part of the audience, 84% have said the member of the caring medical team should be the one to do that. And then the next poll question again will be on ethics, and I will launch it. If you don't see the poll, please go to your screen on your phone and tap More, and then you'll be able to go to polls / quizzes and be able to respond to this. We shall take 50% of the audience. Once we hit that, then we shall close the poll. So upon what principle should brain death definition be best? Should it be based on the family, medical ethics, or should we understand it as legally considered legally considered death? I think from Dr. Agaba's talk, we should be able to answer this question now. Okay, so we have more than 50% of the audience. I'm sorry if you are not able to respond. These are the results. So over 90% of the audience selected medical and ethical basis for what is considered death. And I think in most countries legally it will also be considered death. If you look at most of the cases in those countries. And then the final question for the poll will be, how long after brain death confirmation is it reasonable to wait before life-sustaining therapies are discontinued? And so you can please respond to this. We shall take about 50% of the audience again, and then we shall jump into Dr. Kabweru's talk. In the meantime, Dr. Agaba, please feel free to respond to the questions in the chat, which may be quite many, as we wait to open up the discussion to the audience following the presentation from Dr. Kabweru. Okay, so we've hit more than 50% of the audience, so I will share the results. I'm sorry if you're not able to respond. And most of the audience says up to 48 hours post-diagnosis. 57% of the audience says so. All right, I think that marks the end of all. One more, there's one more poll question, sorry. There's this poll question. After the diagnosis of brain death, should CPR be done in case of cardiac arrest? And I hope Dr. Kabweru will be able to answer this. Again, we shall take 50% of the audience. The audience is, we hope that 50% represents the entire. Okay, so we have more than 50% of the audience. So I will stop it and then share. And so 80% of the audience said no, we shouldn't do CPR after a patient has been diagnosed with brain death. And I think that I think one more question, yes, one more question on ethics, and that's that will be the final question. Is family consent required to withdraw life-sustaining treatment when appropriate diagnosis of brain death has been made? Okay, this has caused a lot of controversy. If some of you have been paying attention to what happened in Britain, a child, 13 years, participated in an online challenge of asphyxiation and was found by the mother to be unconscious and was taken to the hospital. I think they switched off the mechanical ventilator on Saturday, but there was a legal battle in courts of law to try and prevent the medical team and the hospital from switching off the mechanical ventilator, which is considered life-sustaining treatment. So we shall stop the responses as soon as we hit 50%. I think we have, and so end the poll and here are the results. The majority of the audience says yes, family consent is required. So I think Dr. Kabweru has had enough idea about the audience and what their ideas are regarding ethics of brain death. So I will request Dr. Kabweru to share his slides and Dr. Erasmus to introduce him. Thank you.
All right, thank you very much, Dr. Cornelius, and thanks to everyone for participating in the poll once again. We are now doing a home run. It's our final presentation of the day, and definitely where a lot of issues tend to arise. So kindly pay attention and stay on till the end. So our next speaker is Dr. Wilberforce Kabweru. Dr. Kabweru has really, I would say, a guy with multiple trades here and going to be a resource to us. He is a consultant general surgeon and currently works with the Mulago Hospital where he heads the thoracic and vascular surgery unit. He has taken keen interest in bioethics, in which he's currently pursuing his master's, and also heads the professional and ethics branch of the Uganda Medical Association and Central Branch. So he will be taking us through the ethical aspects, ethical underpinnings of brain death and its related complications, and hopefully it will help us to break down the difficulties we face dealing with this situation and the clients. So Dr. Kabweru, kindly project your slides and take over. Thank you.
Thank you very much, Dr. Erasmus. I'm not able to share my slide. I don't know why. Can I send you and probably you try to share on my behalf?
Sure, please.
Okay.
Dr. Kabweru, you should have permission to share since you're a co-host. I'm not sure why.
Yeah, let's try that before we go for the other option.
In the meantime, Dr. Agaba, there are questions for you in the audience chat. And audience, please, in case you have any questions for Dr. Agaba, please post them in the chat room so that he can respond to them, and so that at the top of the hour, we do not have many pending questions that require you to ask.
Cornell, can I speak? It may be
Yes,
easier if I talk, but
yes,
there's a lot of interference, so I apologize for that. Now, I think I have already answered your first question about the poll. There was a question in the poll that was about clinical diagnosis. You cannot make a clinical diagnosis without the blood gas. You really need the blood gas. If you can't do, if you are unable to do the blood gas, then you will need to do an ancillary test on top of everything else that you have done. Can we diagnose brain death immediately after you have return of circulation, and how long should we wait before we can assess brain death? Yeah, so this one is no, you cannot diagnose, or you shouldn't even be doing the determination of brain death at that point. You will need to wait at least 24, 72 hours. If they need, or if they qualify for you to do hypothermia for them, then you will need to wait 72 hours. If not, you will have to give them at least 24 hours before you can do a proper assessment. There is really no test you can do immediately after ROSC that will give you a reliable answer. Okay, so the cardiac arrest in itself is a confounder, so I wouldn't advise you to do that. There are cases of patients who have had a different exam and yet immediately after ROSC, they really look like they're brain dead. So no, you shouldn't be doing. Then there's a question on okay, that was on the slides. The presentation, I think, will be made available. In our setting with medical cadres, I think I have answered that, Tomanya. It really should be someone who has experience doing this and can do it well, and is also is confident in their own ability doing it. The truth is that even around the world, there are few doctors, even though they do it, they still have insecurities about their own ability to do the exam. But it's also because no one wants to be the one who kills the patient. So it's not an easy thing to get people to do. Who makes the brain diagnosis in our teaching setup? Most senior person in the house. So some of these questions can only be answered by hospital policy. But the general practice you will see is usually going to be the most senior doctor. And that's, I think, what happens in Malawi. In the other facilities, it is probably the intensivist and maybe a neurosurgeon usually, who will have examined that patient, and then they will decide that, okay, this patient is brain dead. But normally what you will observe is that the process is not done well. In their defense, some of these patients are probably, the care is futile, but some patients need to be given the opportunity so that there is really no doubt about the patient's state. And I think that for a lot of the cases, the process is not followed well. And we may just be becoming prophets who are fulfilling our own prophecies. I think that those are the questions I can see from here.
Okay, thank you very much. Dr. Erasmus, please, Dr. Kabweru, please go ahead.
Thank you very much, Dr. Cornelius, Dr. Erasmus, Dr. Agaba, and the team for inviting me to give you this simple talk. I think I would very much on the ethical implications of brain death in the ICU. The controversies are quite a number, because there are those medical controversies, there are philosophical controversies, their ethical, their legal controversies, so that it would be much than what we can take today. Can we proceed to the next slide? So where do the controversies usually arise from? The inconsistencies in the concept of brain death, whereby sounds more of a Western concept. In African setting, it becomes very difficult to explain to somebody that actually your husband or your relative has died. The brain has died, but the other parts are still okay. Then the issues start from there. But also the criteria that is used, as already explained by so many of the previous speakers, there is like the one we're going to see, the one which we have in the Constitution of Uganda, and then what is current. But there is a lot of controversies from country to country, from state to state. And then the practice that I'm also going to pose to you, what are you practicing? And obviously, the documentation of brain death. I think if we did a study on most likely a retrospective study on the brain death that have been documented in Mulago, we actually ruled on one that was actually done by Dr. Nachibuka and Dr. Nakwagala, 2009, which gave them a run of the institutional skills. And then by both international and within countries. So this is also covered with diversities in people's backgrounds, cultures, religious affiliations, and trainings. You realize that people from different institutions actually, they have been trained differently, and even when they are working together, they will have a lot of challenges to make the diagnosis because they will choose what criteria to use. We have had religious affiliations. Most Catholics and the other, I should say Christians, for them, they believe life is sacred and it can only be taken by the Creator. Whereas when you come to the Muslims, sometimes when they see that most of the organs have gone, since they say that you need to go to the Jannah when you're still warm, they will accept faster compared to the Christians. Cultural backgrounds. We have different cultural connotations we shall have a look at as we go ahead. Why brain death criteria? There are so many assumptions. In the West is mainly for organ transplant because as we shall see ahead, that most of the countries have advanced directives. People make their wills or wish lists or wish preferences when they are still fine, when they are still healthy, and when they reach in that incapacitated state, then their advanced directives come into play. But mainly in the Western world is for organ transplant. Whereas here, even them a bit, there's family requests, especially in our setting, to come to terms with the bad news. But also legally, because as we shall have a look at what is happening in our country, that our law has not yet been updated, but the reality is actually don't wait for updates, the law, because they take precedence. And then there's lack of frameworks. These may be legal, ethical, and then professionally they may be there, but ethical and legal are the difficult ones. Obviously, the social are quite intense. And then the physician, this physician may make a decision because he's looking after the patient, and he may see to it that actually the patient is no longer benefiting, so it is not worthwhile to continue looking after that life. To proceed, another slide. So the areas of ethical issues in our setting, we shall look at only those 6. The lack of updated brain death criteria, limited resources, surrogate decision-making, cultural connotations, and lack of critical care facilities, and lack of local research. Can proceed. So when we look at the Ugandan Constitution, we are still using the cardiorespiratory criteria, which is obsolete, and it is only understood by a few healthcare providers, but we don't know what the general population actually has. So when you really don't know what the general population has at stake or at mind, then the questions start there, because these are our clients, these are our customers, and who should actually take up what we have. So the current protocols talk about brain stem death as being the brain death or total cessation of the brain functions. However, different states, even in US, take up different criteria, but according to the Universal Determination of Death Act, you realize that actually when you have the brainstem death, in most cases, other parts of the body, the vital organs won't be supported, and eventually you'll come to die. So what is happening in our country? Due to the fact that actually that we provide critical care services, and most of our patients actually don't want to stay in their homes when they are sick, especially when they are very sick. So we have so many patients who come into the hospital, and some of them end up in the critical care areas, and some of them end up being supported. So there is need for enabling a legal framework so that the technical team works ahead of time, and we update the cardiorespiratory criteria that is being used, the current one, so that at the end of the day, we are able to provide a service that actually is internationally recognized and legally within legal terms, so that you are not sued. Obviously, the other big question is, what is the practice now in Uganda? What are you doing, my colleagues, our colleagues? Or what are we doing all? So a number of ethical issues were interfaced when a study was done to assess how patients and their families and the palliative providers were interacting. And they realized that as most of the Western world, they have already protocols and SOPs and policies around death and dying. In our setting in Africa, the family actually is the most recognized that can settle the ethical storms and then even protect you legally. That's why so many times you go ahead to call family conferences, because those are your protectors. Otherwise, if they go out of hand and then they say you switched off without their consent, then we start other battles that we really don't want to engage into. Can I proceed? So brain death is a diagnosis of exclusion, as my previous presenter, Dr. Agaba, put it right. And there's a number of diagnoses that you need to rule out, and you come up with a diagnosis of brain death. So it means it leaves so many things in a gray area. And that's where also ethical issues start. Because if you really don't have a diagnostic test to confirm completely or to rule out other confounders, then ethical issues start there. But even the legal battles start from there, and obviously medical. So as already discussed, that we don't have good diagnostics everywhere in all parts of the country, whether private or government facilities. So that becomes a very big challenge. So even the government can't commit much, and even most of the institutions, as we shall see. So they have left most of the responsibility to the critical care team to lift that burden, but also it overwhelms. So when this becomes too common, like it was the COVID-19 pandemic, then it becomes a bit difficult for everybody to swallow when he has not understood the concept of brain death. So in the face of trauma patients, I think this is where we have a lot of issues. And as I alluded on it earlier, that when they start organ transplant, this will actually start the biggest issue, because this may be the source of organ for the rest, because trauma is not effective unless in most cases, unless if someone had other underlying comorbidities. But these trauma patients, the biggest challenge we have, they are brought to us unknown, and most of the times the immediate family is not there. Sometimes they are brought by minors, police, bystanders, and worse, the people who bring them, sometimes they have taken away their identifiers, like ident cards and whatever was belonging to them. So this makes consent very difficult. And obviously, you know that these are incapacitated, they cannot make their own decision. So issues really are quite a number. Let's proceed. The next slide. So surrogate decision making. In our setting, we don't have advanced directives. Those are living wills. And most people actually even don't believe in them, even in the other normal wills that are made for property and other things. People say, you want me to make a will and the next die, or you want to kill me, or you want to take my property. So this concept has not yet come into our setting, whereby people, but a few of the community members have made living wills. But also upon their death, they are contested because the family has a lot of stake. So we don't have those documented wishes or preferences prior to becoming incapacitated. So it creates a big challenge, especially in this era where in African setting we have extended families, and we don't have a legal framework in terms of the hierarchy for who is meant to make that decision when, for instance, somebody is capacitated. And I just gave an example that just imagine a married man becomes incapacitated, having gotten into an accident. Who makes the decision? In most cases, the wife would be the appropriate one, but you know, in our setting, if you have 10 wives, the young one comes, he says, okay, the other one comes, no. You have connived with the young one to say that you killed our breadwinner. Sometimes, should it be the adult children, or should it be the man's parents or grandies, or male siblings, or friends, or neighbors? So it still puzzles our care, unless in the US, where it is clearly stated who should be your surrogate decision maker. And in most cases, most of these people have made their advanced directives, and they make life a little softer and easier. So this poses a big ethical challenge for the critical care providers, institutions, and the worst to the government. Proceed. So cultural connotations. Most people think that dying in hospital is elegant and is prestigious. And it's due to the fact that so many times, just imagine you woke up and you heard that my father died at home. The first statement that most cases they will say, Dr. Kabweru neglected his parents up to the extent that they died in their homes. But most people prefer to die in their homes. And it's because we have not had research done, and we have not really taken up this concept of death, dying, and where people want to die. So, and this was even worsened by the COVID-19, where we needed to make priorities. Low priority, high priority patients. And diagnostically, if somebody had a lot of electrolyte imbalance and he had a very almost 80 to 90% lung involvement, and he had other issues, and he was diabetic with other comorbidities, so many times we thought, and he was a little aged, elderly, you would think wouldn't be of any priority compared to a young person who came in less comorbidities and less lung involvement and so many things. So when you look at all these, and yet at the same time, there's lack of adequate beds for advanced care in both public and private facilities. Wow, the whole thing actually becomes quite tricky. But these are areas where most of the ethical issues start, because people really don't believe what we are giving. But as time goes by, I think when we introduce the concept, I think it will come to settle under all those diversities. Next slide. So lack of critical care facilities in the country. This, when you actually look at Dr. Kwizera and Tumanya and the rest, we have realized that so many people have died in the hands of we. The we are the ones who don't now provide critical care. Why? Because critical care teams are very few in the country. So they are the scarce human resource in the country, and that is known world over. It's worse for our country, whereby I think we have only 1.3%, 1.3 bed for each million individual in the country. That is quite a small ratio. So other resources are even worse. So this being the order of the day, it makes ethical decision making very subjective. So if it is not objective, then it becomes difficult to actually put your hand down that actually I should provide this. Nobody will commit. For instance, if you have a very sick patient and he has been diagnosed with brain death, in most cases, if you want to continue giving some medication before the family settles and probably the drugs are out of stock, you ask yourself, should it be me, the doctor, to provide, or the hospital which has run out of stock? Or I should tell the relatives who are going to actually to ask you, why are you still giving drugs anyway? And so it poses a lot of challenges. So there is need to redefine ethical decision-making for limited resource settings in terms of infrastructure, trained human resource, equipment, logistics, and the rest. So this poses a very, very big challenge, and we should be equipped to see how to move out of this. Next slide. So because of the paucity of local research in ethical issues around ICU, when you are faced with a patient with brain death, this actually has caused a number of issues. So as citing that Nakwagala and Dr. Jane's publication of 2009, whereby family refused to consent to terminate the life support machine until the patient actually breathed the last breath. It was one of the biggest documented challenge. But I know there are some that are actually swept under the carpet or that are not brought to the earth, and those ones that are kind of critical care areas, and they need to be documented, and we see way forward. But also there is the role of facility-based ethical frameworks, like clinical ethics committees. They are meant to actually lift off the burden from the intensives who is thought to be conflicted, in that is the doctor who has diagnosed brain death, and so he should be off the hook to make a decision alone, because at the end of the day, he wants to look after the patient, but also he has to make a decision to terminate. And sometimes studies done elsewhere, they have found that most of the intensivists are very stressed about some of these psychologically. So the other thing that research on dying, death, and the handling of critical care, critically ill patients, including brain death, is still very scarce. So it leaves a gap for us to continue the search and continue doing research. The next slide. So my acknowledgement is of those few people: Dr. Nakwaga Fred, Dr. John Barogare, Dr. Paul Jabyami, Professor Mwaka, and Professor Sawankamba and Sassen Program. Thank you very much for listening to me. God bless you.
Well, thank you very much, Dr. Kabweru. Dr. Erasmus, I think I'll hand over to you to open up the discussion and maybe have some responses to some of the polls that were responded to by the audience.
All right, thank you very much, Dr. Kabweru. Thank you for packing it in and getting us quite dispersive stuff. Definitely the question of ethics remains very broad, and this is just, I would like to believe it's just the tip of the iceberg, but quite very helpful in putting this into perspective. Dear audience, we shall be concluding soon, but quickly I would like to welcome questions to Dr. Kabweru. I see on the chat, Dr. Cornelius has shared a document that should be very helpful to everyone, just to get an idea about brain death and matters around it. So Dr. Kabweru, one question from Dr. Ruth. Is there a specific document if one wanted to write an advance directive in Uganda? Is there a specific document they would have to fill out, and how would they go about that? Most of the guests want to plan for death.
Actually, it is not there. That is the other thing. I have one of my colleagues who is doing her research around the advanced directives, but the literature, I couldn't get anything, even in courts of law. The document available in the hospitals is not there. By the way, even the other thing that none of the hospital in the whole country has a clinical ethics committee. So we are still novel in that area, in the clinical ethics area. So that document is not anywhere close.
All right, thank you. Maybe also just your thing is not advanced directive generally has to have an input from an appointed attorney, and it's like more of an affidavit, you kind of swear and really ratified by the attorney to state what exactly you want to be done to you in case of critical illness, in case of death, brain death, among other things. It's a legal document, and perhaps maybe in the legal environment, maybe there's something that they do close to that, similar something called a will. But yes, I agree. It looks like the practice of writing advanced directives definitely is not in our setting, and it would be nice that the people who are knowledgeable about these health workers should pioneer that.
Dr. Erasmus.
Yes, sir.
I think let's have a discussion on this and maybe get some opinions. I'm sharing the poll question, and maybe you can get some comments from you and Dr. Kabweru. So the poll question was about consent requirement after withdrawal to withdraw life support when brain death has been
Thank you very much, Dr. Cornelius. Can you hear me?
Diagnosis has been
yes, Dr. Kabweru.
Yeah.
You can hear me?
Yes, Dr. Kabweru, please go on.
Yeah, thank you very much. Thank you for that. Actually, that poll was very right. That in case where you don't have advanced directives, even when you have, the family actually is key at taking up the. Actually, that is the reason I wanted to ask who, Dr. The one who Kalungi, because the reason why you delay withdrawing the life-sustaining treatment or intervention or life-sustaining machine is that you want the family to agree and then accept and then get prepared. Because I think one of the studies that was done earlier showed that so many times people were being terminated prematurely, and the people, actually the left behind members of the family were undergoing a lot of psychological stress, torture. And actually even now I have a patient, I think a pharmacist, a lady who lost the husband during the COVID-19 second wave when we lost so many patients. she still calls and she says, I wish she was given an opportunity to go to ICU and they see her husband. But nobody denied her, but the decision to make that either I go to do tomorrow was the challenge. So this is very key, that the family is at the center of everything. It is actually, in our setting, is the legal part of us to protect us, the health workers, and then the so-called interests of the patient whom we are losing. But sometimes they don't know the wishes of that patient, or sometimes they know little, or sometimes they just now come into agreement with that. And this actually is what prompted my question that I wanted to ask Dr. Kalungi. What was the need for intubating the patient that they got? Was it for the mother, or was it for the sake of the baby? Because also that has also a lot of controversies. I know when I come back to talk about the controversies, especially if you want to do organ transplant, there are so many cases we will discuss, and we see how best we may go around that when organ transplant comes into our setting. Thank you.
Thank you so much, Dr. Kabweru. I guess, again, it's a very difficult thing to handle, as Dr. Kalungi has been mentioning on the chat, handling issues around end of life, for a patient who has had a catastrophic injury, because frequently they have been okay and something happens acutely. It's not like a chronic illness where you could see death coming and you're able to prepare them. So there's a lot to deal with in that situation. But I guess the biggest issue is communication. That's probably our biggest weapon here, communication. If you are communicating clearly and well with the family from the beginning, they will understand that you are really dedicated towards fighting for the life of this person. And when things are not working out, they also understand that you've done the best you could. And they have not had a reason to question you when the answer now is that the patient not going to make it because they've got brain death. And definitely the process of withdrawal of care, which is really a difficult word ethically and also in practice, whether you should use the word. The stoppage of such therapies should be easier depending on how much rapport you've had. There is a question, Dr. Kabweru, of what happens in our setting, and I'd like you to answer that as an ethicist here. What happens when the family refuses to let you discontinue care? What procedures do we follow as health workers? Thank you.
Thank you very much, Dr. Erasmus. I saw Fiona Newman is the one who asks, what if the family refuses? And then the same question Jackson asks, is a DNA do not resuscitate allowed and followed in Uganda? For example, if a patient has it signed and the family does not agree. So I am going to answer this the same way. I'll use Dr. Nakwaga and Dr. Jane's scenario that happened to them in 2009 when they called the family conference. There was better administrators, the director, the senior colleagues. They sat and brought the family to table so many times, but the family insisted they should not stop. They should not remove their relative from the machine until you breathe the last. Until that happened. So when the family says no, that's what you follow. Because when you go against the family, they will sue you. Now, if they sue you in our setting, you actually go behind the bars because you won't be protected by the law. The law still has the other updated one of cardiorespiratory, which has been still working, or it has been supported, yet the brain has gone. So we need to update that protocol so that it covers everybody. So in our setting now, if they took you on and they say no, you leave. And probably what may put them out is the medications that they have to buy because we have a lot of stockouts. And worse, we don't have a hospital policy. So that's why I faced previous ED and the current ED, and I talked to her about reactivating the clinical ethics committee, because that can decide, and it will involve the intensivists and other people in the hospital. So it usually looked at as without any conflict of interest. So that will be that may be our push, me and you, so that actually clinical ethics committees are set up. And when you send that consult, if they refuse and you send a clinical ethics consult, then they sit and make a decision. Still, they engage the family and tell them what challenges they are going through, as we have stipulated up there. Thank you.
Dr. Rasmus, there's a question. Dr. Kabweru, what if the patient has had diagnosis of brain death appropriately done, and the patient sustains a cardiac arrest and the family requests to have CPR? What should the medical team do?
Actually, since that is within our mandate, there is a protocol, Dr. Cornelius, you know it, that when you have two of the vital organs and they're already injured, and then someone gets a cardiac arrest, I think the policies, the protocol is like, there is no need to do a CPR. Suppose someone has a heart failure, and then he has a renal failure, and then he gets a cardiac arrest. What kind of person are you going to come up with? You're going to end up with a persistent vegetative state that even when the patient survives, is going to be very, very expensive to the relatives, to the hospital. These are patients who are going to be crippled on the vent or something of some support, or they are going to be on the CRRT for a long time in ICU, and you're really held up between the hard rock and the rough surface. So I think that's where, as the clinician, probably would explain to these patients and to tell them the patient already has a has already brain death, and you're not going to, there's nothing you're going to sustain. Eventually we'll get another one.
Yeah, maybe Dr. Kabweru, thank you so much. Maybe if I could just interject a bit here. Now, what happens is, there's a lot that I feel is not well understood, and maybe it will never be understood regarding decision-making around CPR or no CPR. Of course, in places where we don't have a lot of guidance, we try to look for the best practice out there in areas that apply to us. I think for us in Uganda, given that we are colonized by the British, we shall be using English common law, among other things. The issue is that we need to look at CPR as a bridge to cure. So in other words, you must have a potentially reversible and curable problem that should get a patient back to life, potentially when treated, and now becoming more interest, a patient being able to get back to functionality. So the simple dictum I follow is that if a patient dies because their heart stopped, you give CPR. If the patient's heart stops because the patient died, they don't get CPR. In other words, if the patient's vital organs, especially the brain and other central organs, are perfectly fine, and all that has happened that the patient had some deranged physiology and the patient's heart stopped, you go ahead and provide CPR for them. However, if the patient has been in multi-organ failure, or in this case has got end organ failure, an organ that you cannot replace, particularly the brain, then you have no business doing CPR. And as such, CPR is actually a medical decision. So you make a decision based on the ability to meet the patient's goals. The goals being a goal of getting back to life and a goal of getting back to functional life. So if the patient has a condition that precludes return to that, then beforehand, it should be decided that this patient is not for CPR. And that should probably apply to many patients who have got catastrophic brain injury, in whom the outcome is predicted to be quite poor, and therefore a secondary insult from an acute acute insult, like in a cardiac arrest, will definitely be even far worse. Those patients should ideally be declared medical DNR from the beginning. And that is a decision that we take as physicians, and just involve family, communicate to family about what the plan is. That's how I kind of have learned to approach the idea around CPR. The challenge is CPR is painted in the public eye as a silver bullet that fixes patients' problems. And so when you present as though it is this nice silver bullet that in case the heart stopped, you could offer or not, it's like in a restaurant. So everybody's going to choose it, and becomes difficult for you. So I think a lot of this is addressed by the shared decision making that you perform as a physician together with the family in reaching goals of treatment, and keeping them involved in care. It helps the journey. It is quite difficult to suddenly come down with an acute insult that means your life is gone. It's difficult for the family to deal with it, and difficult for us as health workers to deal with it too. So concerted efforts from the beginning definitely help a lot. I still want the man of the moment to continue, Dr. Cornelius. So I do have another poll question that might be maybe to conclude this since we're going past time.
Apologies. I think all the poll questions have been answered. I think just a bit of response to some of the questions asked in the chat room. So oftentimes when we're going to diagnose brain death, of course, as soon as we have eliminated all the potential confounders and we have established that the patient is in what we would consider an irreversible coma state, then the next thing is to perform the assessment, and then that's the initial assessment, and then the second assessment should be done I think about 12-24 hours after the first assessment, and that should be done by someone completely separate from the previous team. And once that person, the second person, establishes the same findings as the first person, then at least in most countries, including the UK and most of the countries around the world, in high-income countries where the systems have been designed and the policies exist, the person would be considered dead at that point. But the time of death will be considered as the first assessment that was made that diagnosed brain death. The second assessment is confirmatory to the first one. And so if you're going to write time of death, you actually write the time at which the first assessment was done. Of course, the ethical issues in Uganda would abound a lot, because Uganda, one, is a very young country. Number two, we don't have a lot of the legal framework in Uganda is not there, like Dr. Kabweru said. However, like Dr. Agaba has highlighted, where Uganda is deficient in the legal framework, often it reverts to the common law. So what would happen in that case is they would use cases that have set precedents before, even if they were not in Uganda, to make a determination. I would be interested in reading that paper from Dr. Nakwaga and Dr. Jane in 2009, and reading the circumstances that surrounded that particular case, and also whether brain death diagnosis was actually adequate at the time. I think one of the things we fear as a medical fraternity is that we have, due to lack of solidarity within the fraternity and lack of policies, there is a weakness that anyone who goes by the name of doctor will be considered to have an expert opinion on a topic they have no idea about. And so the challenge here is that, for example, the scenario of the child I talked about in the UK, you can Google the name. I think he's called Charlie Battersby, something like that. He's about 13 years, who died recently. Raised a lot of issues, and that's because the hospital policy is that when someone is legally diagnosed to be dead by the medical team, then there is no more need to continue any form of care. And this child was diagnosed to be brain dead by multiple experts. The family went to the legal route because of a faith-based organization, and all courts said the care must stop. I think they appealed to the European courts of law, who declined to listen. to the case, and the hospital eventually withdrew care. But when you say withdrew care, it does not mean that as medical workers, we just switch off the machines and walk away. What it means is that we provide care to the very last moment, but what we withdraw is life-sustaining treatments or therapies, including mechanical ventilation or vasopressor support. And these are the things that would sustain someone in the ICU. Without them, there would be no existence of brain death diagnosis. And so the diagnosis of brain death, because it came as a result of ICU support care, and ICU in Uganda is pretty young. It's a very alien concept in the minds of many, including medical workers. But unfortunately, it is here, and so we have to start to make a pathway to making sure that these things are instituted within the legal frameworks and the policies within the hospitals, as well as starting with educating the masses about the potential existence that you could die and your brain could go, but your heart could still pump. And this is where Dr. Kabweru rightly says that we need to reconsider the definition of death as a country to include neurological death by neurological criteria. So I will end there with my submission and hand over back to you, Erasmus. I don't have any more poll questions. I think they were all answered.
All right, thank you very much, Dr. Cornelius. So in just a few minutes, I'll just run through some of the comments on the chat that might be our, action points going forward. I see some very useful comments here. So, of course, one is from Dr. Fiona. I propose that in the setting where there is scarcity of bed space and organ donation, when brain death is being diagnosed and confirmed, the physician should be at discretion to discontinue therapies, and his complete family is done. I guess there was also a suggestion that perhaps the AU could lead the way in developing criteria and protocols over this matter, which is quite a good suggestion. And then maybe just a small comment finally on the subject is that there's a lot of controversy around even the use of certain words. We used to use the word life-sustaining therapies as though when someone is brain dead, they're not really dead. So that is partly where the controversy comes in. So maybe until you have a good word to refer to the therapies, we're talking about that sustain the heart and breathing in a person who is brain dead, maybe that might help. And then, of course, the question is whether you should use the word brain death or just use the word death to make the conversation easy. Because when you say brain death, someone is now wondering, okay, fine, the brain is dead, but at least I can still have the body and other things. And maybe that makes it controversial versus how we've accepted cardiocirculatory death, where the heart stops, everything stops, there's no more perfusion, and everyone accepts the person is dead in that situation. Just a few areas of dilemma. So there's a kind of an interesting case going on in Auckland on a young J. McMath, a little 13-year-old who went for an ENT procedure and bled after surgery, aspirated and suffocated and died, got brain death. Admitted to ICU, confirmed, and currently there's a legal battle and back and forth going on, regarding how to go about the case. And I think they're still entrenched in that case. Quite good discussions in American Journal of, in the Journal of American Medical Association. You guys might find it a good read. Regarding how to handle difficult family physician interactions regarding this situation, there's a nice article in Up to Date on handling on. There's a nice article on Up to Date on how to handle situations on potentially futile care, and this situation falls under it. This helps you to understand your outlets in the situation. You don't want to fight this battle alone. You might want to involve other physicians. You might want to involve the hospital ethics committee where it exists. You might involve the medical council, the legal process, among other things. So there is a lot of guidance, and of course, in the absence of guidelines locally, we have to use what is best practice elsewhere. I would not like to drag on. We've gone 20 minutes past our time. I would like to thank all presenters for participating today. Dr. Joyce for the case, and Dr. Claire for taking us through the pathophysiology and enriching our understanding of the process of death, especially by neurological process. Dr. Peter Agaba for the expansive discussion of diagnosis, communication, and certification of this death. And then finally, Dr. Wilberforce Kabweru for taking us through ethical aspects. This topic is rich. This topic is fat. The conversation never ends, and hopefully we shall continue to converse about this and one day come up with our own protocols. As we go home, first, be safe. Second is think through what we've discussed today, and next week we shall start on something new. Next week we are taking the conversation to something that puts together the aspects we've been discussing, and that is the aspects to do with sepsis and sepsis care. It brings together the cardiovascular aspect, neurological aspects, renal aspects, electrolytes, among other things. So again, for those who are interested in participating in the conversation, please join us. Otherwise, for now, thank you very much for all your participation and the conversation that we had today. I wish you a great night and a great weekend. Till next time. Bye-bye.
Bye-bye. Thank you very much.
Good night, everyone.